Good afternoon, Mr. Chairman, dear colleagues. It's a very privilege and an honor for me to be here. Just would like to thank the organizer for inviting me, and in particular Dr. Serdaroglu and Dr. Tuzun. I'm sorry I couldn't have the chance to see Server here, but please give him my best regards and best wishes. Today we will talk about genital warts. The time is not so much, so we will try to condense and share with you what, in my opinion, is the most interesting things to discuss today. So I will discuss about some clinical and treatment clues. My talk today will cover about three main points. Some discussion about definition, some interesting news about the diagnosis, and some more interesting news about management strategies. I'm sorry. So, the new trend in the research area, in the literature, is to define this infection as genital warts and not condylomatous. Condylomatous is flat condyloma, growth condyloma, so it's very confusing, even for residents and for general practitioners. I think it's very important that we all speak the same language. So, genital warts is internationally accepted because it's a clear definition, suggesting a viral infection. Condylomatous may refer to one clinical expression and not all to clinical patterns. Genital warts may be a definition more acceptable and more understandable to patients. So from now on, I will define whatever you see in the slide as genital warts. I will not mention the words condylomata anymore. You all know what these are exactly genital warts. They are caused by HPV, mostly 6 and 11. Remember that there are more than 100 different types of HPV, and we have HPV 1, 2, and 4 for common warts, 6 and 11 for genital warts and Buschke-Lowenstein disease, and then 16 and 18 and more for neoplastic lesion. Remember also that may appear as a single or multiple, may be confluent, pink to brown papules, raised, smooth, sometimes flat papules, different size from 2 to 4 millimeters. They tend to proliferate, and if we do not treat it, they may spread to nearby areas. We know this. Spontaneous resolution may sometimes occur, rarely, however. And those are some clinical aspects, just for the young colleagues here. So you see small papules that can merge into larger plaques with the cauliflower aspect. Those are on the glands, on the prepuce. You see here may be limited, they may be widespread. And here you have a condyloma, but the patient also has a wart on the end, so also consider the chance of autoinoculation. Again, we have cases in which the localization may be a little bit troublesome, like this, and this may also pose a problem for a therapeutic approach. We can also have warts, genital warts on the shaft, on the skin, may appear as a brown papules, as this. And you can have skin and a prepuce involved, and the glands, you can have massive warts like this. Again, also female, you know, they may be affected as well with the limited lesion or with widespread lesion. Sorry, the computer is not okay. So it's female. And also don't forget that also the area, anal and perianal area can be affected. So the diagnosis is generally clinical. We all are able to do a diagnosis. Remember that genital warts are sexual transmitted disease. Acetic acid, a low specificity, especially on the skin. We don't do viral typing except for unusual cases, as well histology we don't do on a routine basis, only for selected cases when we suspect degeneration into cancer. This is the second part of my talk, the diagnosis, new clues. I know that there are a lot of sessions on dermoscopy. We do dermoscopy in Italy also on non-pigmented lesion. We have done this on genital warts. It would be nice to share with you our experience. What we have found that in papular lesion, there is a whitish network, circumscribing areas centered by dilated glomerular vessels. You see this pinpoint here? So we have these areas, and those areas are subdivided into small areas which are centered by this red, which correspond to glomerular vessels. Here you see a higher magnification, and it's pretty clear, this whitish area centered by all these glomerular vessels. This is typical of genital warts. When you have cauliflower lesion, multiple irregular whitish projection arise from a common base and comprising elongated and dilated vessels. Here you see here. And histologically, this pattern correlates with papillomatosis, hyperkeratosis, and acanthosis. Again here, this is obvious genital wart, but we do just to see if the pattern is repetitive. Yes, if you see carefully, you see this glomerular vessel, which are typical of genital warts. Of course, we can use this technique for differential diagnosis. Those are the ones in which we can try to see if dermoscopy can help us to rule out or confirm the clinical suspect of condyloma. And of course, this is particularly useful for small lesion. For large lesion, dermoscopy is not indicated. So in our institution, we do, when we have some doubt, any clinical suspicion, we do dermoscopy on small lesion. Let's see this. This is a common thing. This is a physiologic status. Is pearly penile papules. You know, there are monoform, uniform, and monomorphic papules around the corona glands. Many patients complain and they are afraid that there are penile warts. Anyway, do another case here, another example. And if you do dermoscopy, we see this whitish pink cobblestone of grape-like structures. As you can see here, there are no glomerular vessel here. It's all this white spot here, cobblestone, whitish pink. Again, here you see that's very artistic. Some of these images are very artistic. There is no glomerular evidence of that could resemble genital warts. And this is an exemplary case. This patient came to us and they say, "Oh, doc, I have condyloma." I says, "Forget it, you don't have condyloma." "Oh, yes, I'm condyloma." And no, this is pearly penile papules. And then was pointing out this lesion, and I say, "Please, look careful. I want to make sure that," and then, okay, fine, we agree with him. This is the lesion that we'd, and as you can see here, this is the cobblestone whitish papules, typical of pearly penile papule, but this one has this glomerular pattern. So this patient had a condyloma on top of pearly penile papules. So this was very helpful for us to recognize this condyloma, and of course we treat the condyloma accordingly. Again, for this spot here, sometimes for the young, may resemble warts or something else. For this spot as a typical garlands-like aspect, as you can see here, whose bows seems to wind around the yellowish lobules of the spot without crossing them. It's very typical. Again, no evidence of glomerular pattern here. Molluscum contagiosum is another thing that sometimes can mislead the diagnosis, and sometimes you don't have the umbilication, and it's very hard to recognize. And Molluscum contagiosum has also a typical pattern with this central polyglobular white to yellowish amorphous structure, which are crossed with a peripheral crown of reddish linear or branched vessels, which don't usually never cross the center of the lesion. So this is typical of Molluscum contagiosum. Again, this is another case. This is a patient with genital warts that we were treated with imiquimod, and this is the reaction from imiquimod. And then the patient came to us and said, "Oh, I have this." And while he was under treatment, of course, we couldn't imagine that he had sexual contact in this situation, and of course, we told him to stay quiet, and the patient wanted to know, "Oh, how do I treat? What is this?" And so we think warts, genital warts, reactive papules, something else. So we did the dermoscopy, and this is what happened. Those were Molluscum contagiosum. So the patient had genital warts and Molluscum contagiosum at the same time. So we also suggest to apply imiquimod on Molluscum contagiosum as well. Or we told him if he wanted to do curettage, he decided to go on the imiquimod. Angiokeratomas, sometimes also, as you can see here. But again, presence of dark lacuna, red lacuna, and whitish veil. Again, no evidence of this typical glomerular pattern that can confuse this lesion as pigmented genital warts. Seborrhoic keratosis. We see him, I don't know how common is in your practice, we see cases with SebCare, and you know that SebCare has also an unequivocal pattern on dermoscopy, horny papules, pseudocyst and comedon-like openings here, which are typical of SebCare. And finally, lymphangiomas. This is a very unusual case. We were ready to do biopsy. This is a case in which the clinical presentation was very unusual, so we decided to do dermoscopy first before doing a biopsy. But then dermoscopy showed these multiple yellowish patches which are related to lymphangiomas, so we decided to not perform a biopsy. Finally, this is a patient with these papules. He had a previous history of genital warts. He wanted to know if it's a genital warts or not, and then we didn't know exactly. Then we decided to do dermoscopy. We could not find any evidence of dilated or elongated vessels. We did a biopsy anyway, and it was also only sclerotic tissue from a post-surgical scar. Finally, this is something else, something that we described, is median Rafe cyst, which is also unusual. It's seen on kids, on children, and we did a dermoscopy. It's very interesting. We see these lesions, which are cystic lesions, and are typical of infants or in childhood. For large lesion, we do a clinical examination for differential diagnosis. So do not forget, sometimes you can have lesions like this, which are an epithelial, fibroepithelial polyps. Of course, we have extensive genital warts like this that should be differentiated by penile horn. The approach is completely different. In this case, remember, you will always have to do a biopsy here to find out what is at the base of the penile horn, if it's a genital wart or is a carcinoma. Though remember that 1 out of 3 of cases of penile horn have at the base a cancer. Again, extensive genital wart like this must be differentiated by verrucous carcinoma like these two. So sometimes when the lesions are very extensive, it's not easy. And so when you are not 100% clear, always do a biopsy. Again, extensive genital wart must be differentiated from the most aggressive penile cancer, which is the squamous cell carcinoma. Another recommendation before finishing this part of my talk and going to the last part is, in my experience, when you have patients with recurrent clinical warts, genital warts, always look for other sexual transmitted disease. Those are patients who do not wear condom. So, as they were exposed, the same way they were exposed to genital warts, in the same time can be exposed to other sexual transmitted disease. So in my experience, we have many patients with recurrent genital warts who are also positive for syphilis, who are also positive for chlamydia or for Neisseria. So please check for underlying other sexual transmitted disorder. Those the last part, which I think is one of the most exciting also, how do you treat genital wart? What exactly in your mind determines which is the choice of treatment? In the literature, there are some recommendations, the aspect of the lesion, size, morphology, the extension of the lesion, the localization. Most importantly, also patient preference. Most of my patients, they say, whatever you suggest, but please, no surgery, no needles, no blood. So it's something that we have to consider, and also our experience in the field should also take it into consideration. Of course, thick and keratinized genital warts generally resistant to local treatment, so there is no way that we can suggest a local treatment in a situation like this. There is also, it's very debatable if in cases like this we have to use electrosurgery under local anesthesia or CO2 laser. This is up to our experience. Remember that when we use invasive technique, the risk of recurrence is higher. Localization of the lesion, we show a case like this. Of course, it depends on your experience what to do in a patient like this. And patient preference, you know, most of the patients, of course, they like topical treatment rather than having needle or having CO2 or laser or whatever. Finally, our experience, don't do something if you are not able to do it. The best thing is recommend, if the patient wants to go for a laser and you have no experience with that laser, send it to a colleague, but not try to do things that you are not experienced on doing. That's my recommendation. What the literature says about treatment option. This is from Mark Lebol, which is our Bible for treatment, especially in Europe. You know that the rates, the treatment are rates as A, B, C, and D according to the amount of literature of the randomized clinical trial. So the number, the one with A are topical imiquimod and podophyllin or podophyllitoxin. Then if you see, cryotherapy is B, and then the remaining are COB. Promising option is a photodynamic therapy, which is something which is expanding in the last year. Just a few considerations. Remember that when we use a treatment, we can use anti-proliferative therapy like podophyllitoxin. We can use destructive techniques like cryotherapy, electrical needle, excision, etc. Immunomodulation therapy, imiquimod and interferons, and combination therapy, so we can combine, or also antiviral therapy, cidofovir, but we rarely use in Europe cidofovir because it's very expensive. So the treatment options are, with A, are imiquimod cream, which is an immunoresponse modifier. It is the host immune response that clears the warts. So it's a peculiar mechanism of action, does not destroy the tissue, but stimulate an immune response to clear. Recurrence are very low, and usually is self-administered, so patient can do it at home, and is 3 times a week for 3 months or longer. This is the podophyllitoxin, a different mechanism of action, blocking the polymerization of tubulin, and cause destruction of wart tissue within a few days. Just to show imiquimod, there's plenty of references in the literature regarding its mode of action, and This is something that we have to consider. I think this table is very useful for the clearance rate. You see, they all guarantee a pretty high clearance rate, but the recurrence rate, especially for destructive technique, is pretty high compared to topical treatment. How should patient with recurrence be managed? What is interesting is patient with recurrence, which is very common, check for subclinical, intravaginal, or intrauteral. So don't insist on treatment when you have a patient with recurrent genital wart. Think that there could be something else behind. So it's very important that you stop 5 minutes and you check if there are subclinical, intravaginal, intrauteral, or anal lesion that could justify this recurrence. Check for unsuspected immune deficiency. Considering reviewing the diagnosis, Bohenoid papillosis, Buschke-Lowenstein tumor, or if the disease is atypical. Do a biopsy if it's necessary. There is also some news about combination therapy, which means that unfortunately there is no single treatment that achieve 100% effectiveness. So the new trend in the literature is to combine treatment. So medical therapy followed by ablative technique, or ablative technique followed by medical therapy. This is a new trend. Of course, ablative technique followed by medical therapy should be done by experienced physicians. For bulky lesion, surgery can be the initial therapy, and then we can add medical therapy after surgery. This is a paper in which there is a combined treatment, you see ablation alone, which is associated with almost 30% of recurrence, and then ablation with the imiquimod is associated with from 26.4 to 85% recurrence rate. This is my last part. I'm ready to finish. This is the algorithm. So please consider it that we can have appearing or increasing lesion or stable lesion. When you have appearing or increasing lesion in which there is a growing tissue, then imiquimod is a chance to consider. When you have stable lesion, which means you have lesion that date after 6 months, you can have fused lesion or multiple or extensive lesion. And then at this point, for small lesion which are stable, the suggestion is to do excision or cryotherapy. And then in case they recur, you can consider imiquimod. And if you have remaining lesion, then you can start considering again ablative techniques. If you have multiple or extensive lesion which are stable, it's up to you or your experience. You can start with imiquimod, you can start with cryotherapy, and then if you have remaining lesion after imiquimod, you can go back to ablative techniques. If you have, after cryotherapy, recurrent lesion, you can go back to imiquimod. So it's very important to alternate. The mode of action of imiquimod can cause erythema, and when you have a patient like this, you don't have to use topical steroids. Just when you have a situation like this, you have just simple reassure patient, no treatment is required, and just wash the area and stop the treatment. You can have another option like this with severe erythema. Don't worry, just stop the treatment, apply cold compresses and just wet medication, and it will go away as this. Finishing.
Sorry. Yeah.
When you have a patient like this with vulvar erythema, application of imiquimod, just wait a little bit and the inflammation will go away. So don't worry, don't change treatment. It's, you only have to get a little bit of experience. Finally, this is my last case. This is a patient in which I would like to refer to your experience. This is a patient, young patient with diabetic with thrush, so he has a candida, and on top of this he has also a viral genital wart. What to do? We don't want to inflame an area which is infected by candida. So the advice is to treat candida first and then to apply imiquimod. So use an antifungal. Once the candida is gone, then you start the treatment with imiquimod, and this is the result. So my conclusion is that dermatologists play a pivotal role in the diagnosis and treatment of genital warts. Therefore, in my opinion, it's very important to be updated on new diagnostic and management strategies in order to offer the best performance when dealing with these common dermatological disorders. Thank you very much for your time.